Hey everybody, and welcome back to another edition of the Physiotutors Podcast. Today I'm speaking with Ian Gatt, the head physiotherapist for British Boxing, the upper extremity for the English Institute of Sport, an educator, and currently working on his PhD in wrist biomechanics, if I'm not mistaken as well. Ian, but that's enough from myself. I'm sure the listeners would much rather hear from you. Why don't you give us a quick 1 or 2 minute intro, and then we'll dive on in to the topic of today, upper extremity injuries in combat sports.
Yeah, hi, Sonny, and thanks obviously for having us on this episode of Physiotutors. Yeah, I've been in sports for 20 years now. I think it's always been a passion to go into sports, and I managed to actually venture, crack that nut that they say, first you have to get in, and then the second hardest thing is you have to stay there, both from the hours that you end up working, but also obviously it's making sure that that passion remains, and the passion has remained. I mean, 20 years I've worked with diverse sports. Probably the most prominent is in over more than a decade now. I've been with Great British Boxing, been their head physio for all that period, and the last 2 years obviously been promoted to head of performance, which is actually, it's pretty much a new role even for boxing, which allows me to have a wider look around the other disciplines. So we've got 8 disciplines in boxing, and including myself, we are 16 practitioners. So actually it's quite a big team that supports over 40 boxers, lots of coaches, and obviously the wider team, the PD, CEO, and everybody that goes with it. So it's a nice family, as we like to call ourselves. And it's important that we talk about Olympic sports, because this is an Olympic year, was meant to be last year, being postponed exactly 1 year due to COVID, and fingers crossed. I know obviously things don't seem too great generally in the world, but at the moment it seems like everything is going away till otherwise told. Apart from that, I dwell into research, whether I proof articles or whether I'm involved directly with research. In fact, I'm also doing a PhD in wrist biomechanics in boxing, which is an area which interested me a lot from the very beginning when I started, because I saw the lack of, let's say, knowledge, but also understanding around bandaging of the wrists. And obviously the injuries in boxing, hands and wrists, are quite predominant. So, from the practical side, the curiosity side, and dwelling a bit more into the research aspects. And linked with that probably is education. Over lots of years now, I've been involved in education, either working with different providers or trying to do my own courses, which then sometimes end up through providers anyway, particularly around the hands and wrists, but even the rest of the upper limb, so the elbows and the shoulders. And lastly is I don't work in a private practice, but I see private clients. I think it's good for me because it allows me to see either athletes which are not at that very elite level, but also to see sometimes your general public. Sometimes people will say, well, things are different between sports and people in the general public. I'd say there are differences. Obviously, there are differences from the epidemiologies you see to a certain degree. But a joint is a joint. And I think the understanding of certain basics, going back to anatomy and mechanics, which I know, again, it's criticized a lot in social media these days, should you know anatomy? And I'm one of those simplistic people that say you have to know the basics. You don't need to understand every single component of an engine to drive a car, but you need to have an understanding of where you put your screen wash and where the oil is and, where your nut bulb is. If you don't know those things, don't jump into a car because you're going to struggle. So that's a bit of me. Like I like to do different things, but obviously the passion remains all around sports.
Great, fantastic. And I imagine if you don't know where the oil and screen wash goes in the car, you're in for a bit of a bumpy ride.
Don't put it in with the oil.
Now, I think that's one of the things that my mentor has instilled in me over the last few years as well, of the biomechanics and the anatomy. So long as you have that basic understanding there, you can work out what's going on for most anyone. So it's refreshing to hear that, as like you say, on social media, that gets a bit of a battering at the moment. Obviously, look, the upper extremity is really vague, just to put it as a bracket term like that. You got your shoulder, you got your elbow, you got your hand and wrist. There's a lot going on there. Why don't we break things down a little bit, and we'll start at the wrist, talk about maybe what the most common 2 to 3 injuries are that you see there, and then we'll move up, go to the elbow, and then come a little bit more proximal from there. What do you think would be the most common injuries that you see within combat sports, within the hand and wrist?
Yeah, so if you take the hand and wrist combat sports, you have to imagine there's this contact. And as a result of that, you have to expect your acute traumatic injuries. But also in itself, it's worth understanding that there's an overuse also type element of injuries. So, your acute traumatic, you can have your fractures, but depends also, and that's why I like to talk about mechanics sometimes, because if you have the right protection, obviously we're not talking about a pop fight or you go and whack your hand against the wall. That's where the mechanics sometimes are really interesting, because if you talk about fractures, let's say you talk about your metacarpals, these two joints over here, your second and third metacarpal and your carpal, so your carpal metacarpal joints, those tend to be very much unmovable, or they move a little bit. And as a result of that, if you hit somebody, the forces actually will tend to displace more your ligaments. Whereas because your fourth and fifth CMCs tend to move more, because you have that torsion happening, you tend to see more fractures over there. So quite interestingly is where you tend to see fractures versus obviously you tend to see like ligamentous injuries. And I think it's not a rule of thumb. You might still have those vice versa, but that's probably more of a common thing. So injuries you tend to see are not so much muscle strains as you would see in other places of the human anatomy, where you expect even around shoulders sometimes, the elbow, the biceps, but then in the lower limb and the back particularly, like big muscular areas. But the hand and wrist, it's more your bony injuries. But even more, sometimes it's even worse, because more than a bone is the ligament injuries. And I think if it's a bone, it's black and white. If it's a fracture, you want to detect it and you want to manage it. If it's a ligament injury, can you manage the symptoms, first of all? And also, what does that mean? I like to talk a lot about form and function. So is the form gone and affecting the function, or is the function affecting the form? So as a result of that, what I'm getting to is if you have a torn knuckle, which again, these are common injuries that happen. So obviously if somebody's punching, you can imagine that you're going to have injuries in those knuckles. If you're an injury of what is known as the sagittal bands, I have seen sometimes people with lots of pain and minimal findings on scans and vice versa. So actually sometimes just because somebody has a particular tear on a scan, it doesn't mean they're not going to return back to full training with zero symptoms, because you can manage those things, because the hands and the wrists are quite particularly even around symptoms, the representation, the homunculus of the brain and so forth. So to answer your question, obviously I got a bit long-winded. The main areas you have to think about are your knuckles on impact, your long bones, your metacarpals, the carpals, the small bones. So obviously you have to think about your scaphoids. A bit more proximal, then you have to think about, again, things like your TFCC. So that overuse particularly, but you can get acute traumatic. But then let's not forget Mr. Thumb, that especially because its orientation is different to the fingers, especially when it's caught out, you can get injuries. As you get in other sports, you can get your UCL injuries, MCP joints. You can even get a bit worse injuries, a bit more proximal, so your first CMC, like a Bannett's fracture or dislocations happening in the area. Not as commonly maybe as you get in sports like your volleyball and basketball, but you do get finger pathologies. So sometimes you could get a jersey finger, and sometimes it's not because the finger extended and you get hit on the area, but because obviously the finger is closed. Boxing, you have a glove and it's closed. Obviously you can get impact there, but let's not forget other sports like MMA. They probably have less protection in order to grappling things. So because of those grappling, you're going to see injuries that maybe are not as similar to boxing because of the sort of change in the way you use your hands and wrists.
Yeah, no, absolutely. I've had a fair few wrist issues and elbow issues from training in MMA and also competition as well. It's probably, I'd say, from my experience, the carpal injuries that I've seen with my teammates as well from that. And with the carpal injuries, is it more capsular? Is it more related to the mechanics of the joint? Why don't we start there and then we'll work back a little higher up the joint? What do you see going wrong with the carpal bones normally?
Well, the carpal bones are very complex. I think I've been lucky by doing the PhD to understand how complex they are. Particularly there is a drive of like one bone on one side impacting on the other bone on the other side. So the scaphoid is a key bone Hence why when people get injuries at the scaphoid, scaphoid fracture, scapholunate injuries, the complexity around that impacts on the mechanics. Injuries to the carpals can happen either because you have that, could be a clean shot where you hit somebody, but because of the movement happening, the distortion at the wrist, obviously the force is increased there. It could be that somebody falls on the floor. Think about a lot of sports like judo, UFC, MMA, you could fall down on an outstretched wrist. That's it's not a common injury in basketball, but if you go and you dunk and you fall on your hand rather than your feet, you can imagine the amount of force going in there. And, these are big guys, so you can even visualize it better. And then also from the grappling itself, all those torsional forces happening. If somebody is catching on somebody, in judo particularly, they have the clothing on. In other sports, they're obviously a bit more bare. But if somehow your hand is twisted and put in a better position, you can twist lots of things. The ligaments tend to be the ones which get affected the most. And because of that, then it creates that integrity goes. If you think about, moving a bit more proximal to the carpals, but impacting on the carpals, if you think about the FCC is made out of different components, depends where you look it up, but traditionally about 6 components make up the TFCC. A lot of us think it's just the discus, which is an integral part, but then you have the ulnar carpal ligaments, the DRUJ. So, there's lots of components there. But the TFCC and your scapholunate ligaments, particularly, those 2 structures are probably 2 of the most important structures for stability of the wrist. So if you're getting problems there, it's going to affect stability. And then obviously, one of the things that really beyond the stability is the symptoms. So then it's an understanding of how much of that, let's call it structural stability, is lost that can be made up by the dynamic stability, kinetic stability, because actually the wrist likes stability, like many joints to be fair, but it really likes stability to be able to have a shoulder which moves, an elbow which moves, and then, you grab on something. If you think even in these grappling sports or even in these contact sports, when you impact, the wrist is meant to be stable. It will move, but because of what you're doing, you're trying to create that stability. It's not like doing a handstand and you're going into full extension, you're getting that full range, or if you're doing sports like tennis, where potentially it is quite stable anyway when you're doing a backhand because the elbow is the moving part. But then as you are creating that effect at the end, same as you would do in golf, you are creating that movement. So I think as a result of that, you have to think that the wrist wants to be stable. You're not trying consciously to create a stable wrist. But then injuries happen is when it's taken away from that stability. Let's call it equilibrium if you want. The equilibrium for me means that in most sports, you have like an optimal range where it tends to work. And don't get me wrong, some people have more of an individualistic thing. Some people may move in that range. But if you are forced away from that, as you see in other joints in the body anyway, you will get injuries.
How are you going to go about assessing these then? If we just look at that wrist area first, what's your approach to the assessment?
Yeah, so the first thing, and I think it's mentioned everywhere, history is the most important thing as a starter. Is this a traumatic injury? Is this an overuse injury? Do the symptoms come acute or are they chronic? And I think people get a bit confused also with these terms. At one point I was pondering, people talk about acute and chronic and almost make it like an acute is always a traumatic. It's not the case. Acute and chronic can be either traumatic or overuse. So I think it's best when you're dividing injuries to either say, was there a traumatic episode that they can remember or not? And if not, possibly it falls into that overuse element if you can pinpoint it. And then where the symptoms are acute, they just come on like this, I felt this one day, or now they sort of came on gradually. And how long have they been now? Have they been there like 3 months, 6 months? How many people did you see? What has been done? Have you been injected? Have you been operated? And to be fair, a lot of times, by the time people tend to see me, they actually have gone through quite a few people, which is fair enough. I don't run my own private practice, so expect people to access people in their localities. Then they struggle a bit and then they come and see me. The answer to your question is, I try and go down back to basics. And I know, again, there's a lot of debate on social media around it, but I like to use objective measures as a starter. Now, the objective measures aren't to tell the person, this is your diagnosis. but it's a good way of prognosis. I have done quite a few different webinars, and I teach on this, around objective measures, particularly at the hand and wrist. And I think range of motion and strength for me are two aspects which sometimes we learned at university. I think we didn't learn them well, and probably we learned them wrongly at the time. But like anything else, when I was at university, that was 20 years ago. But I don't think these days also that people are learning. I think the hand and wrist is the area where people almost like a bit forgotten. Everybody does everything else. The backs, the knees, the shoulders, for sure. Ankles, get in the spine too. And then suddenly you're left with a hand and wrist that nobody knows what to do with. If you start with those, it gives you some prognosis. And let me try and give an understanding, because people sort of misunderstand what this could mean. If somebody comes and they've had symptoms or issues for, let's say, 6 months, let's say a year, let's say they've got scans and the scans are saying all different kinds of things, and surgeons have told them all different kinds of things, and physios, we are really bad sometimes, we'll tell them all kinds of things, and same with doctors. As anything else, everybody will be opinionated about things. If you test somebody and their strength is good, if you do their hand grip, power grip, if you do the pinch grip, check the thumbs, if you check the range of motion, which for me comes almost secondary, because I first start with strength, because strength is your function. If you have full strength and you have no symptoms, that's for me is a positive straight away. Because if somebody can squeeze something, make a power grip, and that's only one of the grips, and they have no symptoms, that's really positive, because that means that you can, grab your cup of coffee, you can lift up your bag, you can do lots of things. Then the other thing you want to see, obviously, just because you can make a grip, it doesn't mean you can weight bear through it. So the next thing is to understand is, can they weight bear? It's still an aspect of function. And another thing, that's where people also get the wrong idea. When you're doing a strength measure, you're not necessarily measuring strength. You don't look at the number as you can squeeze 30 kilograms. Let me go and get my list from publication and see where you fit and see whether that's normal. That's the wrong way of approaching it. One is comparing left to right, if you can, hopefully you're seeing an able-bodied person, they can squeeze both sides, but it's looking at the function. It's looking at what they can do. It's looking at whether they can do it repeatedly, whether they feel comfortable doing it. And that can give you a bit of a picture. And I've had people who had no symptoms and were good, think thumbs up, people which have no symptoms, but they have lost strength. They are dysfunctioned because over time has become a bit disused. And it could be obviously down and they have pain. Sometimes you'd be surprised, it might be pain, but they squeeze to it and actually have good function. But give you an idea, I had somebody who was actually not an athlete, he was a roofer. This roofer had a bad accident with the hand, had lots of types of intervention, lots of rehab, lots of strength work. I asked him whether he ever loaded his hand, whether he ever hit back with a hammer or this thing and that. And you could see the terror, the fear in his face. The first thing I did is checked his strength. Strength was good. Then I got him to weight bear. He was very fearful initially, but we got him through it. By doing those things, we reassured him that there was nothing wrong, that the hand, he's not going to shake it and he's going to hear things crackling in his hand. And as a result of that, the person returned actually from within the same week, started going back to certain activities. Why? Because a lot of times, if we don't have something to back us up and we are not confident, what we'll do is, same as parents can transfer their fear to children, we've probably heard this a lot, we as therapists can transfer that same fear to somebody, because they're asking you a question and they're telling you, is my hand good? And you're like, well, I'm not too sure, and the scan says this, and what has your surgeon said? And well, whereas if you have something tangible, you already have somewhere really good to go. And I always feel comfortable, not because, I've just started doing objective measures yesterday, it's because I've been doing them for 20 years in sports. And I can see in sports what those measures tell us, the safety net it gives us, the security to tell the athlete and the coach whether they are fit to return. And for me, I transfer that even not just in other sports, not just boxing and other sports, but also in the general public.
You mentioned the grip strength, pinch grip, power grip, and then also the weight bearing for the wrist as well. Now, For the weight bearing, I'm assuming that you don't just mean wrist on the table, lean forward. I'm assuming you mean physically holding a weight, maybe holding it in a particular position and seeing how long they can do it. You mentioned endurance there for a moment. Can you maybe expand on the different grip strengths and how you're going to measure those, and then also the weight bearing as well for us?
As I said, luckily we cover these a lot in the different education platforms we've done. So, you've got three types of, well, you have lots of types of grip strengths, let's put it this way. But the best way I've managed to break it down, especially in sports, is to have three, which can be used quite nicely because then you can test them and it gives you a very good idea. Yeah, you've got your power grip, which is literally when you make a fist, and you can use hand grip dynamometers for that, which are widely available. You can then look at your thumb, and with your thumb, I tend to use two. One is the pinch grip, which literally is where the pulp of the thumb approximates with the pulp of the index and that middle finger. There are different things you can use. One of the things I actually like to use a lot is the handheld dynamometer, which is widely available for other joints, mainly because of the width that it has. And that usually I tend to find it biases better, because if you use what is classically known as a pinch grip dynamometer, it's a bit too small. And it means it might be good for the joint, but doesn't tell you a lot about the ligament, because the ligament is quite relaxed. So you think about your UCL in a lot of an adducted position is very relaxed, whereas as you abduct it, you can bias it. And then you've got your key grip, which actually the pulp now of the thumb approximates on that lateral aspect of your index finger. And again, that's really good because we use this quite a lot, even in different sports. You can imagine the sort of grip when you start looking at different sporting ergonomics, or even in general public. And again, it's probably useful for that joint integrity. And now it is more of an adducted position. So I think between those three, it probably gives you a good idea of what's happening around that sort of hands and wrists. And it could be all three are fine, two or three are fine, one out of the three is fine. It's just trying to get an understanding of what the problem is. The other thing sometimes is just because somebody has had a pathology somewhere, the chronicity of it may not be dictated by that same area. I'll give you an example. Somebody had a previous injury on the ulnar side of the hand, and you do a hand grip 6 months later, maybe you expect it to be weaker, and you don't. But then when you do the thumb, you find that's weak. And it could be, as I say, because you have to be careful with inference. I think that's another big thing we always have to be careful. But if there's gross weakness in the thumb, it could be that the problems happening here, especially in sports, is as a compensation. Think about it in tennis. If you're holding a tennis racket, you tend to use a lot of the thumb, and the thumb is weak, and you're getting ulnar-sided pain. It could be because the thumb isn't holding well. And it could be you actually have had a history of tendinopathies in the thumb, or you haven't. So it all depends. Those are probably the three types of grips I would tend to use.
Okay. And the weight bearing was?
Yeah, the weight bearing is actually the former you're talking about. It's actually weight bearing. Now, you can use endurance tests, don't get me wrong. You could put somebody with a handheld outside of a table and put a weight, which is obviously reflective of their body weight, and see how long they can hold it. But one of the things I like to do is, because obviously if you are squeezing something, yes, you are putting force through the hand and wrist, but directly you're not putting weight through it. So if you are, for example, a boxer, if you are a gymnast, it's actually good to have that. Now, you can either do one-off tests where you can either do what we call like a push-off. So you actually push off the table, pushing up, or you can do a push on like press up on the floor. And that gives you a very nice way. I'd call it more qualitative. Can they do it? Yes or no? If you then want numbers, one of the best things to do is get one of your, so a normal scale, analog or digital, just something that you can actually get a number, and you can do it one-sided. So, when you put the weight on it with the one hand, how much can they tolerate? And so, for example, if you are on an all-fours position, you put the knuckle there, you put the other hand flat, and you start putting the weight over it. So you don't actually push, you let the weight come on it. What you do is see to the point where they can tolerate, see how much weight they've put and how much pain they give you. And that becomes your objective measure. Example, if they have 50% difference and they say it's a 4 out of 10, okay, well, that's moderate, pushing into the higher scales. If somebody can hardly put on any weight and it's quite painful when they get there, that's telling you quite a lot, versus somebody who can pretty much put 90% of the weight and maybe has a 1 out of 10. So it's just trying to add something to have a bit more objectivity. And obviously, don't get me wrong, you will get the information. So I don't know, if somebody says, when I'm hitting a bag, I feel I can only hit 50% and the pain is 3 out of 10. That's very useful. That's functional. The only problem you have there, it's very subjective. There's nothing quantifiable, not unless they're hitting a force plate mounted against the wall. But the only problem you have with that is that ecological validity. So don't get me wrong, if you had one and you can use it, great. But you actually have other tests which you can use, which are probably more indicative before having to go to that sort of higher degree. Because for me, in boxing, as an example, if a boxer can hit all those marks, they can do, they can load through the wrist, they can do all these tests I'm saying. Don't get me wrong, we're lucky because we have an isokinetic machine too, so we can even do the higher level of testing to make sure the strength is also good, because even in the absence of pain, it doesn't mean that there isn't weakness, and we need to sort of identify it. But if all those markers are good, the next step then is to check on a bag as an example. How hard can you hit? 80%, 90%, 100%. I can hit 100%, no pain, good. All right, let's progress you to other things. So it's trying to get that sort of something between the functional activity and almost like I'd use the eyeballing. So having something a bit more quantifiable.
What about things like range of motion in your assessment strategy? Are you paying much attention to that as well in helping to diagnose injuries?
Yeah, so it's, again, I wouldn't use the word diagnosis because I think it can assist your diagnosis. What I mean by that is both the strength and the range together can help you formulate an idea. If you hear the history, the sport, the sort of type of pathologies, you check something, it gives you a high clinical suspicion. And I think that clinical suspicion, then you need to think what you want to do next. Do you just monitor it? Do you want to scan it? Yes or no? Because, just because we're in sports, it doesn't mean you have to scan everything under the sun, which sometimes people might think about. But range of motion for me becomes important also, because especially if it's chronic, you want to see what's happened, but also acutely, also if they are after an operation and they've had a period of immobilization. I think for me, if somebody has had an acute injury, I won't go straight away for range. I probably go more for the strength element. I might just say, can you move your wrist? And I just eyeball it because it's an acute injury. And usually you expect these to sort of progress well, unless then they start taking a bit more time. They almost become into the subacute phase and the chronic. Versus strength for me is almost the first thing I'd do straight away, even immediately, as soon as I've come and see you. But range of motion, yes, it's something that you have to, again, I wouldn't do it everybody. You have to have that clinical understanding of what information is going to give you. So if somebody comes after 12 months of struggling with pain, definitely I'm going to have a look at range of motion. And I'm going to look at, obviously, all the motions related to that hand and wrist to make sure I don't miss out anything.
You mentioned imaging there. Do you make much use of it, or do you tend to rely on your clinical findings more so, or does it really just depend on the time for whenever the next event is or something, if there's any haste behind it?
Yeah, well, that's a very good question, because I think, again, we're fortunate, we've got another 3 full-time physios. We've got 3 doctors working with us too. So, when we have our medical meetings, including myself, you've got 7 brains talking about it, rather than you're left alone to make decisions. I think that's really good conversations we have on whether we scan or not. So rather than we go, should we scan? Yes. Actually, we push each other into trying to identify what the scan will do, because one of the things that sometimes we need to understand is the scan going to change our management? And we do say that a lot. Is the scan going to change our management? No, it probably won't. Then we use the word however. However, considering the importance of the time we are now, considering the type of athlete, what we don't want to do is miss out anything, which potentially is something that we might need to have in mind. The other thing is also having that explanation to the athlete. Now, just because you find something, as we've seen from lots of scans, it doesn't mean that relates to the symptoms. But having that something underneath gives you an idea. What do I mean by that? If you scan a wrist and you find a particular tear, grade 1, grade 2, even grade 3, whatever it is, it gives you an idea what's happening under the hood. If you are 3 months before a games, and maybe with the type of symptoms and the type of injury they have, traditionally you would have considered thinking an operation at the back of your head. One of the things you have to do then is think, okay, can this be managed? So you'd get a second opinion from a surgeon who works with you, who knows you, and then you try and formulate a plan together to see if this is manageable. Because the last thing you want to do is just remove an athlete. In a normal circumstance, you might have thought Olympics goes on 4-year cycle. If you are in the beginning of the cycle, you might have a lower threshold for operations because they've got 4 years ahead, and you want maybe that structure integrity not to come and bite you later on and almost be like up and down with the symptoms. But if they are very close to a games, you want to see if that is more manageable. And obviously you do certain things more acute, let's say, be doing probably more hands-on, let's put it this way, for the people that probably hate the sort of that contrast of hands-on versus rehab. But you have a lot of rehab, lots of hands-on, and you'll be on them quite a lot, because what you want to make sure is that they can manage the load and they have no problems from it. But scans, sometimes you may have certain things where you are a bit bewildered and you are a bit unsure. So it's good to have that extra bit of information. But what we don't do is scan every injury. Otherwise, we'll be literally have more people in scans than we have people over there. I go back to the objective measures. Sometimes the nice thing about objectivity is you see somebody today, it looks bad, 10 out of 10 pain, 80% loss in strength. It looks a grim picture. 3 days later, it turns on its head. 2 out of 10 pain, and they have a 10% difference. And you might think, is that possible? Yes, it is, because maybe they've never had an injury in the area and they hear all the other people and they're quite frightened that they've heard somebody's been on operation for the hand recently. Or the opposite, they've had so many injuries in the hand in the past, and as a result of that, previously it's kept them for long periods out, that fear has inflicted on their pain awareness of it. So, us sending somebody for a scan straight away is not going to help. The other thing also is we know that if it is inflamed quite a bit, it may have that impact on contrast of quality of imaging. What you don't want to do is send somebody straight away. It might be different if you are in the Olympics and they have to compete the following day. You probably want to get a scan because you want to cover anything that there is over there. So, you mentioned timing. Timing becomes a big factor depending on what are the goals, the expectations also. When I say by expectation, doesn't mean an athlete says, I want to scan, we scan it, or the coach says we need a scan or a scan, or even if I say I want to scan, we scan it. It's whether it's the right medical decision for that person. And equally, we need to be careful that by over-scanning somebody, we don't medicalize them. As I said, just because the resources are not endless. In the Olympic sports, we are funded by public money. So we have to look after that money. It's not endless resource. But even if I was working in a professional sport and Prince of somewhere in the UAE was giving us all the money, I still wouldn't, buy a scanner and have a scanner under a roof and scan everybody, because I think it sends the wrong message, because then we'll start managing scans and not the person in front of you. And I have seen from all the years that scans don't tell you the full story. They give you something, they help that piece of the puzzle when you need it. But sometimes if you just get it for the sake of getting it, might give the wrong piece of the puzzle. So you have to be careful with scans and even your clinical inference. Sometimes certain people can very easily think they're crossing those T's and dotting those I's, and actually the I's they're dotting are what's in their brain. That's actually what's probably in front of them. It's not easy, and I think it is having that skill to be able to use what is there and putting it into practice. And if you spent a long time in your sports, hopefully you are biased in the right way and you not actually become biased in the opposite way. So, and I think that's why it's probably important to even keep reading all the literature that's coming out around scans in different areas and maybe help influence the interpretation of what those scans are telling you.
It's funny that you mentioned potentially over medicalizing a particular patient, as there's been a few sports teams that I've worked with where, let's say, some of the older guys in the team that have been there for years and have seen X amount of different therapists, they are always saying when they come into the treatment room, oh yeah, maybe we should scan it, even if it's something quite mild, something that actually give it a few days and this will be gone, or you do these little things. And I promise you, by the weekend, you'll be good to play again. You'll be good for the game. And they're like, yeah, but, normally I get a scan for something like this. The impact that can have for that player if the medical strategy is constantly just chucking through the machine, chucking through the machine, chucking through the machine. They just think that is the basic part of the process. And like you say, it shouldn't be a basic part of the process. It should be a part of the process that's added if you can gain some kind of value, be that making sure you don't miss anything, be that it's crunch time coming up to the games, coming up to season, whatever. It also sounded like for some of them, it can be a little bit more symptom management in combination with hands-on treatment, or if they've got games coming up, ice it or something like that. What is your treatment strategy then following your assessment and whatnot? How do you approach that? Do you use anything like splinting for the wrist? As I see that's something that can be used, but I assume if it's coming up to games times, that's something you want to avoid immobilization. So yeah, what's your approach for treatment?
Well, it depends. If it is a traumatic episode and symptoms have gone on straight away, acutely, especially the hand and wrist, like knuckle injuries and those CMCs, particularly the CMCs, like if you get a knuckle injury, your ability to make a fist may not be impacted, but at the CMC, if you actually injure there, you really will impact. So if it's a bad injury, you'll know because they will really struggle, even like turning the doors or grabbing a bottle. So sometimes the best thing to do is to immobilize them for a period of time. Now, if you have the ability, the opportunity, I always try and go for a 3-week period to allow actually the ligaments to heal well. And this has come through experience. So in the past, probably, I used to be more of an aggressive physio, thinking that sent by God to heal everybody on earth. Most physios think we are. I'm joking. But, you have this approach in sports. You are aggressive. You want to return people and everything. And I think the approach was fine. And we used to get them back. But with these sort of injuries, then you used to have a high recurrency, and then eventually they might even end up having an operation. And actually, I've learned this in a way from the NHS, from seeing what practice they do. Because in the NHS, they're not as aggressive and they go very conservative, maybe a bit too conservative. So I thought, you know what? Let's try and bridge this aggressiveness in sports that sometimes you need to versus the conservativeness. I was trying to find that middle ground. And for me, if you immobilize them for a period of time, now if you have the time, if you have the luxury of the time, you've no major coming up and you can immobilize them for 3 weeks and then remeasure, we tend to find is that their ability to make the fist is better, no symptoms. But sometimes even immobilizing them for a few days, if that's all you have, sometimes even giving them 2 or 3 days and then retesting. And that's why I go back to that objectivity. If you've got something, you test, you remeasure, at least you are seeing that what you're doing, whether it's the right thing or wrong thing. If after 3 days you retest, or after a week you retest, or after 2 or after 3, and there's no real difference, the prognosis isn't good. If things are improving, then brilliant. And sometimes you don't even need to scan at that stage. If obviously it's not getting better, then scanning is probably appropriate. Don't get me wrong, if I'm going to keep somebody in there for 3 weeks, I might think about scanning it if he's an athlete, because I need to understand whether there was any damage to the area. But again, it depends on, we talked earlier, the timing, the type of athlete. Is he a priority athlete? What I mean by that is he somebody who's going to a major tournament now, or is somebody who at the moment doesn't have anything on the horizon? That's how we classify priorities. Not saying like one athlete is more important than another, but obviously if you have athletes who've qualified for the games and you are in an Olympic year, they do become your priorities. So your threshold for doing certain things, which normally you might not do, becomes lower. But yes, I do splint, and I do find that it's not only do I splint away from boxing, we splint even in boxing. What I mean by that is somebody who's got the sort of injury, as they are returning, sometimes we'd use even an off-shelf splint, like a Bertoni splint, simple strap, metal at the top, to get back into training. What that allows them is to return quicker back into training, but safeguard the area and actually improve the low tolerance. So as they're then improving, then you start weaning them off it, versus, I'd say, a more traditional approach of get them 100% first or close to it, and then you return them. You see what I mean? And I think that gives them some confidence too. The fact that they have something there giving them extra protection. But don't get me wrong, already you've got athletes there which you are strapping with tape and bandage and everything. So this is just adding that additional support.
And what about in terms of hands-on or hands-off treatments? Do you use much in the way of manual therapy or modalities? Or
Well, it depends. So, we try and use the core of our approach on rehabilitation, mainly because we've seen how much impact it has. And actually, you have a much bigger effect. But we actually find that there are certain adjuncts for certain people that really work well. And what I say, it's not for everybody, but I found that manual therapy can be useful, particularly in the acute, sometimes even in the chronic. You can help. People talk about the placebo effect, the expectation of the athlete. We're not saying we're going to treat, doing 10 or 20 or 100 sessions of this, but you do as appropriate in particular periods. You can use things also like shockwave therapy. I've found shockwave to be really good, but we've introduced shockwave in the last 2 years, probably uses for about 6-7 athletes out of a cohort of 40-50, but it's made a difference in those athletes. Would I use it for everybody else? No, but definitely a hands on wrist with stubborn injuries and ligamentous injuries. Even at the elbow, we've used it for like a collateral ligament injury. We've found good effect. And then there's all the other bits and bobs you can do. You've got your instrument assisted type approaches, which again are really useful. Now, if somebody had to ask me, okay, let me ask you a question, Ian. What do you think you're doing when you're doing that? Because, are you mechanically readjusting something? Are you healing the area with the energy and everything? I say, you know what? I'd like to have a straight answer, but I'll probably be bluffing if I tell you what exactly happens, because even the research is a bit unsure. But what I tend to know is by doing that, I am desensitizing the area somehow. I am desensitizing the brain somehow. And one of the things I go back to is frequency. Shockwaves is a particular frequency. Yeah. If you do mobilizations, we've all learned to do it in a particular frequency. Now, whether it's a grade 1, 2, 3, 500, whether we're pedantic, have you done Cultiburn, Mulligan, Maitland, Syriax, you're moving something, okay? And traditionally, you tend to do it for X amount of times, 5 times, 10 times, 30 seconds, whatever you've learned. And the same with even instrument assisted. I believe that the frequency in which you do it actually somehow has an impact on pain. And nobody should be surprised, because we know that pain travels at frequencies, and a lot of the things we use, tense, interferential, all the things to try and get that acute immediate effect, usually have worked on frequency. So I think a lot of the adjunct techniques we tend to do usually have an impact on that frequency. And that's the way I try and think about it, that whatever I'm doing, hopefully it's impacting on their symptoms and allows us to keep progressing in the rehabilitation. Because for me, the only reason I want to put an adjunct on is because they're not managing to progress to the next level. There's something stopping them. So can we try something, and does it make a difference? Yes, no. As simple as that. But I'm not going to go out there and say that manual therapy is for everybody and shockwave is for everybody and for every condition and everything. And that's why research should be guidance. But equally, I'll be a bit cautious, because if we go with a lot of the research, it's very conflicting. Some people are a bit louder than others on certain papers. If at the moment I had to open social media, I'd probably find that acupuncture is useless. But I've used acupuncture with a few people, fantastic results. Now you want to call it trigger point, acupuncture, you want to call it, you've used the chi and the energies, or you found a key point in the fascia, whatever it is, some people have responded really well. Why not have that in my toolbox? Now, don't get me wrong, I know how people will think, is it worth spending all that money to then, use it? I'd say it depends. If you're working in an environment where just doing rehabilitation works and you're achieving your goals, fantastic. But I must say in sports, it's going to be very hard for them to achieve that, because these athletes are highly conditioned athletes that do exercises every day.
Hmm.
Moving away from rehab, they're in the S&C every day. They're very active. They're not sedentary 50-year-old diabetic people that even just going for a walk might help on their pain. These are very active individuals. So for me, doing the hands-on becomes a cherry on the cake. I think the problem is when you then compare it with Joe Public, is that some people use the cherry without having the cake. They do a lot of the hands-on without thinking lifestyle, psychosocial elements of things, the affinity of somebody to do rehabilitation. You can go through a lot of things. And that's why I think the biopsychosocial model has probably grown more, especially in Joe Public. But in sports, that still applies. The only difference is that we've been doing rehabilitation for ages in sports. But obviously, I know some people get skewed more on the hands-on. I've seen it over the years in some sports. The moment somebody says, I've got a shoulder injury or an elbow injury or a hand injury, say, oh, let me put you on the table and start treating you. All I've done in the last decade in boxing is to try and keep athletes away from the physio table. And people say, why? You don't like to treat hands-on? Are you lazy? No, because I know that every minute on my table is a minute less from them being in that boxing ring. So what I'm trying to do is empower the athletes to be independent. And a lot of times what I tend to tell them is, okay, so you've told me what you've had. I'm going to advise you what to do. If tomorrow your symptoms are still there, come back, I'll see you and we'll see where we go. It's not about, oh, straight away I need to do something to prove that I haven't done something. No. And usually we'll ask the question, what have you done? Have you iced? Have you stretched and whatever? I mean, even ice gets a lot of bad rap these days. Ice is not for inflammation. Ice is for pain. Chuck it on for 5 minutes, 8 minutes. You're doing no damage in that period. If you do the covering and everything, if you use cling film and really make it nice and tight, you get that compression also in the area. And the nice thing is when they take it off, they'll tell you straight away, does it feel better or not? And I tend to use this as a strategy. And I know lots of people are like, what, you still use ice? That's gone out of the guidelines now. It's peace and love. There's no ice in it. Price is gone. It was prized. There was so many of these. But ice, yes, it's not for an acute injury if you're looking at inflammation. But if you justify it for pain, it's the best analgesic. Why do you want to give paracetamol? Why do you want to give ibuprofen, which is even worse? You definitely, for pain, you wouldn't give a pure ibuprofen, like a diclofenac. You might give your traditional ones. If you have something which is a pure analgesic and then you can test them after that, oh yeah, that feels a little bit better, as an example, why not? So yes, I think we do use hands-on, but as a team, we justify not only what we're doing, but for how long we're doing. By that, I don't mean like, oh, tell me how much time you've done mobilizations, but like, is this a long-term strategy? Because if it's a long-term, we need to rediscuss why we're going to do it as a long-term. Because I wouldn't want one of the physios mobilizing somebody for the next 6 months, unless we can really justify that the only reason we're doing it is we're going to do once a week as a little check-in and also as a reassurance for this athlete, because I don't know, they have very high concerns about it. And at the same time, you're getting a little conversation, you know what I mean? So it's not really about the treatment, the hands-on then. It's more about you trying to sort of be that amateur psychologist where you're trying to have a bit more of that psychosocial element beyond the sort of the bio part of things.
It sounds like to me it's more so a symptom modification approach to allow the athlete to continue on and crack on, rather than I'm healing the area. It's doing some modification so that you can get them back into the ring, back into the strength and conditioning room and what have you. Would that be a fair summation for yourself, do you think?
Yeah, because it's nice to see actually that the general public, the mentality of physios is starting to shift a bit, because now they talk a bit more about function and functional scores. Before it was all about pain. And I think that's where we got a bit unstuck, because in sports, our job is training availability. So if I get asked, how would you measure the success of the medical or the athlete health strategy, because not just physio and docs, it's a wider strategy, is how much time can we allow an athlete to be in there? That's training availability. That's their function. So personally, I don't care how much pain they have, not in a bad way, but if they have pain and they can be in full function, that pain is not restricting them. So if we get over-focused on the pain, that's the wrong thing. So what you have to do is, all the strategies we're doing, and in answering your question, it is a yes. It's trying to do everything we can to create symptom modification that allows them to do things. I've had athletes sometimes tells me, I have no pain when I'm boxing, but when I'm lifting a box at home, I have pain. Okay, I'll go, is there a way not to lift that box? You see what I mean? Sometimes what you get is, if you just ask, do you still have pain? Yes, I still have pain. You start going, oh, I've tried everything now. Why is it not getting better? But if you ask, do you have pain when you're doing boxing? No. Do you have pain when you're doing S&C? No. Do you have pain when you're running? No. But when I'm doing this particular activity, which has nothing to do with the sport, I get pain. You're thinking like, we'd like you to get better doing that, but our priority is the sport. And I think sometimes it's try, even as you're discussing it with the athlete, same as you do with a client, what is the most important function for them? Because if they tell you, well, it's not really important for me, but just to let you know, I still get pain, you'd be like, don't worry too much about that then. You're over focusing on the wrong thing. You're focusing on the 2% where you have pain of all your activities, and the other 98, 99%, you're doing really fine. And I think that is really important, because sometimes people don't even get that clarity, even in sports, that the pain is not even in the activity they're doing related to the sport, is in something completely different. And we can fall into that trap in clinical practice, where you focus on it's still painful, and we don't ask the question, okay, when? And one of the funniest things for me is when people say, I have no pain apart from when I touch it. And I'm sure some people have had it. And I know there's the joke of the memes of a fractured thumb, a finger, when everybody touches. But I go, stop touching it then. It's like, I say, it's like you have a bruise. Do you keep touching your bruise to see if it's painful every day? You'll never get better. But people do it. The most common one is tendinopathies. Tendinopathies will get better in functional things before you touch them. They'll still be sore to touch. And I think the problem is we keep touching it, and we just, it's still painful. No, leave it. Stop reminding them it's painful.
Yeah, they come in for their physio assessment once or twice a week or whatever, and the physio goes every single time and pinches on that tendon and says, oh yeah, it's still painful. Look, once you get them back into the S&C room, what for you then is an optimal ratio between their rehabilitation and their normal exercise program, which if you're working with your boxing athletes or athletes from other disciplines, they're also going to have their sports specific time as well. It's not just going to be clanging and banging the weights. It's going to be doing your boxing drills or doing some sparring, doing technique, what have you. What for you then is the optimum for their rehab exercises to that? And also, do you prescribe sort of prehab exercises for your guys as well?
Yeah, some good questions there. So first of all, I'll pick from the last one where you talked about the prehab. Back in the days, we used to do prehab. I probably used to run like a class twice a week. Everybody do a bit of prehab and get them doing like a circuit and everything. But what I realized is that the best way to get the maximum effect is to be integrated into your S&C. So if I go back to the first thing you said, like how quickly do you return them back to S&C? They never lose the ability to be in S&C. The answer would be day zero, because every athlete who's injured is back at S&C from day zero, if they can. If they're operated and, they're a bit sedated and everything, you need to allow them maybe a couple of weeks at home. That's fine, because sometimes you have to give them a bit of that. Depends what the operation is, obviously. But we try and bring them back in straight away, because there's a lot of things they can do. And we know there's a lot of research out there which talks about, working the contralateral side, what they can do on that same side. Sometimes if they have a hand and wrist injury, you can actually put straps around further proximal to the wrist, and you can be moving the elbow and shoulder straight away. All the CV stuff, if allowable, if they allow to sweat. So that's why I was talking about operation, because you don't want them to sweat in those initial first 2 weeks, let's say 10 to 14 days till the stitches are out. But normally in other injuries, they're allowed to sweat, so can they run? Yes or no? Can they just jump on a bike? So I think because of that, when you are devising a rehabilitation program, whether it is an acute injury, whether it is that recurrency, whether it's a chronicity, you don't do a plan on your own. What you do is you work very closely with the S&C guys, because if you want it to be truly individual, you try and see if there are things that can be done in the S&C suite. And actually, rather than do rehabilitation, they become add-ons they become part of that process, that system, which means it allows you, even as a physio, rather than over focusing on the rehab side of things, maybe they're doing 2 or 3 exercises which are a bit more sort of like, not specialized, but maybe they're a bit more low key. You don't want your S&C doing stuff which are a bit maybe in the early phases of the weight bearing. But our physios are brilliant because sometimes they've done joint sessions with the S&Cs. The physio go into the S&C. We use either force platforms to look at the weight distributions, how they're doing things, or, as they're doing it, they see what happens. But the reality is sometimes maybe physios, we do overcomplicate rehab. We make it sound a bit too complex. And I think rehabilitation can be simple if it is simple. What I mean by that is if you give the guidance to the S&C guys and say, look, he can do everything except this, this, and this. And the S&C goes, okay, so this is what we can do. We can do this, 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 and this. Great, crack on. All they need to do is maybe outside of the S&C, a few extras, 2 or 3 exercises, just because you feel that those might complement the progression of things. If you've got an athlete and they're doing 10 to 20 exercises of rehab and hardly an S&C, I'd say you are really not doing the right thing. For me, that's not an elite way of progression. One, because you're missing a big chunk of what the S&C guys can do, and that's beyond the knowledge that they can provide. That's all they do, the prescribing exercises. So the knowledge is truly wide and they can help you with the range, but you can work together also. So one of the things we do at the end of every week, we have a physio S&C meeting and we discuss the athletes, what will impact on the S&C. So we won't tell them about all the people who are injured. We'll tell them all the things which might need tweaking for the following week. Can they run? Can they not run? Can we do this? Can we progress on that? Then they'll send their plans and we proof check them and we come back with questions or answers. So I think because of this to and froing, Physio S&C becomes a very strong unit. It's not working in silo anymore. And sometimes you see, these memes of physios and S&Cs fighting against each other. It shouldn't be like that. It's one unit. The Physio S&C becomes that very strong unit. And what happens is the physios feed the information to the S&C. And the reality is the S&C, in a way, almost progress the rehab, if you see what I mean. You are there just to guide it, oversee it, but you're allowing things to progress more. That's why I said it's more that strong focus on rehab. If then they're not progressing or you think it's important to add certain things, then the physio can focus on the hands-on stuff. And that's why it allows you to become a bit more, not specialist, but if you're using the time, rather than you trying to do rehab and hands-on and I have to choose, it's almost like, what? I'm actually allowing the rehab to shift into S&C. And so I'm using my time for management of the injury. And if I need to do the hands-on, I have the time. Because last thing you need to do is you have a big cohort of athletes and you're running out of time because you can't do things. I need to do the rehab today, and then I need to do the hands-on, and then I still need to sit down and do the plan again. It allows you to focus on certain things a bit better. And that's why I said, with Shockwave, we only sort of started using the last 2 years out of curiosity, out of something which sort of I've read and everything. And obviously there's a difference between radial and focal. One is more painful than another. And forgetting the evidence for a second, I wanted to scratch that itch of my curiosity. I've used ISTM, it has worked. I've used mobilization, it has worked. Can this machine that produces these shocks, can it numb the area? Can it desensitize the area? And actually, can it help people with placebo? We're talking about this is a big machine. I can feel my pain and now it's gone away. Massive effect. But I think sometimes, I don't know, people see it as a negative. But for me, if you can change the symptoms, you mentioned yourself, if you can modify the symptoms, if you can make them more comfortable, if they can feel better and improves training availability and adherence, why not? You're not bluffing. You're not saying, that is healing your torn ligament and is going to bring all the fibers back together, or is going to break down your scar tissue. Don't bluff it. It's going to desensitize the area. There is some evidence it might help the healing in the area, but the main thing is it's going to desensitize it. Can I do more damage on it? No, because from what we've seen, it doesn't create more damage from what we have seen.
I'm a massive proponent of Shockwave. I think it's a fantastic tool to use. And I think even now, a lot of research is going into potentially bringing it into more acute phases as well. You mentioned that you use it with more chronic injuries at the moment, right?
Yeah, you know what? It depends. Yeah, I've used it with acute also. I think, and it has worked really well. I think, let me put it this way: why wouldn't I use it with acute also? Because I do believe in natural history. I do believe the body can heal itself. I don't think that if we are religious and we do believe in higher power, that somebody made an error on the seventh day when they created us, and on the eighth day they created the physio to complement that. There's a natural history, and it's important to allow that to happen. And that's why I am more prone to go into those sort of stubborn ones, more chronic ones, or somebody, let's say they've got a subacute injury, but we're really nearing a competition, and when you've tracked your time scales based on their current progression, you think they're not going to meet it, and you want to see whether there's a way of accelerating things, not healing, but accelerating the symptom modification, but you still feel safe that the healing is going to be safe. Let me put it this way. So for me, if there is a strong justification for symptom modification, I will put it into play. But also, that's going to take 20 minutes out of one of my physios to do it properly. So I want to make sure we're justifying time. And so just do it with everybody. I don't think that's the way forward. I think that you become a technician, and you're not justifying that actually, what I don't want to do is every time we discuss an athlete, are you doing shockwave? Are you doing shockwave? Are you doing shockwave? It becomes, well, might as well employ an assistant physio just to do shockwave then all the time, because that's how we'll end up. Don't get me wrong, we may have some fantastic results. Who knows? But I don't think we should be going down that route. It becomes a dangerous rabbit hole of thinking that actually that is changing, that is revolutionizing the world. But it can make a difference. It can definitely make a difference. And I don't think it's just that. That's why I mentioned before, shockwave, acupuncture, mobilization, anything. Sometimes taping also, even just putting taping itself, that symptom modification for a few weeks, suddenly, it impacts massively on symptoms, weight bearing or non-weight bearing in the upper limb joints. So even K-tape, some people call it bullshit. Some people call it the magic tape.
Yeah.
But it does work. I used to heavily strap volleyball shoulders in the past, and the shoulders in boxing have a similarity in that sort of overhead activity. And actually, since I shifted to K-tape, and don't get me wrong, we don't use it for everybody either, but for some people, it makes a difference. Some people, it makes a difference. And you think like, it's definitely not mechanically changing anything because of the tension you're putting and everything. But if anything, it allows them more movement than traditional taping. And for some reason, it is symptom modifying something. For me, if something is changing, great. If it's not, don't get me wrong, I know with shockwave, what you expect is to have an immediate effect now, today, see something change. Doesn't mean it's going to overlap straight into training. But what you want to see is after a few sessions, you do start seeing a difference. So that's where you go with it. But no, I think adjuncts have a role, but you need to justify it. You can't just treat anybody with the same modality that walks through the door, even if it's the same shoulder, because it's not. Everybody's different.
Absolutely.
Yeah. So Ian, just to bring it back a little bit more towards injuries, TFCC, obviously we mentioned that briefly earlier on. What exactly is a TFCC injury? What can we expect to see in our athletes, and where should we go? What should we do with that?
Well, I think, if you think about TFCC, sometimes it's very easy just to think about of TFCC as a discus anatomically. You think about it, it's the nomenclature really is like triangular fibril cartilage complex. And I think the last one is important, the last C. It is a complex because within that complex, you've got the ulnar collateral ligament, you've got your DRUJ. So there's important structures because your DRUJ is very important for the stability between your radius and your ulna. And you think, especially around the DRUJ, for me, the RUJ together with then your more proximal brother, the PRUJ, form part of that forearm complex. And so with forearm, you think about pronation, supination. So if you start thinking about the type of injuries you get with the FCC, so most commonly it's a degenerative type injury. You can get obviously acute trauma, it's not just degeneration, especially if you think again about your DRUJ. You could literally just fall on an outstretched hand and open that mortise between your radius and your ulnar in a very pronated position. So obviously, or even supinated, and then obviously that can cause damage with your ulnar collateral ligament. If you're getting that sort of radial torsion, so obviously then you start injuring that ulnar carpal complex. You can have obviously acute traumas, which maybe you don't have the immediate issues there and then. You just get a normal acute injury and then you recover from it. But the continuation of certain aspects of instability and mechanisms then creates the basis for TFCC. Now, obviously, one of the most common things you do see is that meniscoid, that degeneration. That's one of the things that's even, when people scan or look for, they have a look at that too. From my experience, a lot of that comes, it does relate a bit to the biomechanical aspects of things. Sometimes one of the things you find very interestingly associated is people start having those lacks in pronation, supination. Pronation probably a bit more, because pronation tends to be a bit more sort of like impacting on your discus, whereas when you supinate, your ECU, extensor carpi ulnaris, probably is the one which gets affected the most, mainly because when you supinate, the ECU tendon, which is in a groove, tends to be pulled out. And at times, you can get tendinopathies, but what gets missed in that area as a differential diagnosis is the subsheath, which is a ligamentous band that holds it together. It's a bit like the ligaments of the knuckle that hold the tendon together. It can get torn, and as a result of that, you don't get the symptoms from the tear itself. You get the symptoms from that irritation of the tendon. So it looks like a tendinopathy, and then it's something else. You can even get FCU, flexor carpi ulnaris irritations, maybe not as common as your ECU, but depends on the population. Recently, I'm going a bit from combat sports to more your sport like rock climbing. I had somebody with bilateral rotation of his FCUs, which was coming a combination from techniques he was trying to do, supinatory positions, trying to do long holds. Classically we think of rock climbers being out here like Spider-Man, but these underarm holds can become useful. But interestingly, it wasn't because of that on its own. It's because in lockdown, he's doing more work on the computer. So he's having to do a lot more work, long hours. So, and a combination of the two seems to have caused that irritation. In fact, over Christmas, he said when he stopped working, his symptoms got better, even though he continued his rock climbing activities, which again is a reminder, not just for me, but everybody else, that it's very easy just to consider the injuries in the sport. So if I take it back to the combat sport, but also you have to think about the lifestyle and the other things they're doing. One of your athletes is studying at university and they're doing a lot of typing to do an assignment. Does that impact on an overuse injury? They're having to do some manual labor over the weekends because they're helping some friend build a house, or they're helping friends move houses. I mean, the amount of times I used to see people with shoulder injuries or back injuries because they've helped people move things, and you think, oh, that's come from S&C or that's come from the sport. It's very easy for us to fall into that pitfall of thinking that, it's a big trap. That what I'm trying to say here is a couple of things from when you talk about TFCC, you have to think about its close partners that make up the TFCC. You have to think about the other partners that maybe don't make up the TFCC but are very closely associated. As I said, FCU and ECU as in tendons. But then you have to think about the wider picture. So beyond the sport is thinking about other things they're doing. And don't get me wrong, if in the sport you're working, you see these injuries commonly and you can associate them typically to some of the things they're doing, then great. But a lot of times think about also things away from the sport, think away of activities. Even, I mentioned S&C. S&C is not the bad thing, it's not the bad beast. But if they've started doing certain activities more, like gripping, and maybe they're starting to overdo it a bit rather than taper it in, it may give them that quick influx of symptoms and a bit of an overload. So I think all these are worth considering.
And what are you going to do assessment-wise for the TFCC if you suspect that specifically? Are there any specific things that you do for that, or is it just part of your normal diagnostic process?
No, so with TFCC, obviously, using some of the things we said before, I'll probably look at, that hand grip strength and pinch grip strength, because I think, especially if it's, when we say overuse, somebody sometimes can tell you it started hurting on Monday and today is Tuesday. They can still have an acute presentation. But if there isn't that sort of direct mechanism, I did this, and it's chronic, but even if there was a direct mechanism, I like to have that objectivity to know what's going on. I definitely look at the wrist range of motion. We talked about it before. And with that, I'd add pronation, supination, because for me, pronation, supination then is giving you a bit of an idea. I'd look at, is there any feel of instability? So, just having a bit of a feel of certain things. So, your radius with your ulna, how does it feel? In neutral and a more closed back position. So closed back tends to be your full supination, pronation movements. Particularly full pronation, you'd expect the radius with the ulna not to move, to be stable. So obviously, if in a mid-prone position, there's normal movement, and then you go into an extreme and it feels pretty much the same, there could be a degree of instability. You check also for your triquetrum with your ulna, seeing if there's any sometimes big gaps or clunkiness going on there. And then you can do I know people have a bit of a tiff with the names special tests. So let's call them clinical or orthopedic tests. You can provoke the FCC. You can do the Physio sign, which is literally pressing in between your FCU and ECU. Is it tender exquisitely compared to both sides? You can do some of the scooping tests, a bit like a meniscal test for the knee. So you're grinding it a little bit. Does it give you anything? You can do ECU tests to see whether it feels stable and intact. So there's a few other things you can do, but I think it's a balance. You get the history. You're looking at things which you can quantify, numbers, objectivity, so strength, range of motion. You do a bit of that physical examination, and all together you're trying to get an idea of what to do. I think the main thing for me is early management. I've seen people with symptoms on Monday get better by the Friday, because if you tackle certain things which maybe back in the years they were more experimental, and in a way they might still be. And again, I know people will say, there's a lot of people out there that say, well, how's there any direct relationship with what you do and the symptoms that people get? But I know that if somebody has symptoms on Monday and they're an athlete, and I've done certain things and I'm better by the Friday, we know we've tackled some things. And obviously, I can't say exactly we did the one thing and it's better, but lots of times you give that. If pronation is stiff and it's causing those symptoms and you've improved that, if you've done a bit of reconditioning around the area, maybe you've given them a bit more advice around support. So you've added a few little factors, they improve. I cannot hang my hat and say that is definitely the one. But I know over the years, we never started with, if I give 3 things now, I never started with 3 things 10 years ago. I probably started with one thing, and then we tried the other thing, and that made a bit better with somebody, and we tried the other thing with somebody else. So the truth is, maybe we do give a more a quicker approach with these things, and that's why we get a bigger answer. And it's probably going to be hard to say it's definitely the pronation mobility things that made it better, or it is some of the TFCC compression type exercises that made it better. But we know that has worked in the past in different capacity for different people, and so giving it to people straight away actually get a quicker response these days. So it's using a bit of that clinical acumen, and then if it's not working, then you think, okay, what else can we do?
Do you ever utilize any taping for this specifically to provide a bit more stability around the joint, perhaps?
Well, in combat sports, it comes with the territory, is it? You tape people anyway. So I think adding more tape just becomes almost like common sense. So if you know that somebody's getting pain, particularly with TFCC, you want to see, okay, is it, do I need to compress these 2 bones together, your radius and the ulnar, because maybe the RUJ is a painful one? Do you need to sort of reduce the ulnar deviation, particularly because maybe that's the compression part, or maybe you stop the torsion happening? So you try and you play around, really. If you get somebody to do something and you provoke the symptoms and you make a movement and then you change things, a bit like the Mulligan approach, is it? That MWM type approach, and a lot of these tapes used, like even the McConnell type for the knees. I always believe that if you open a book and you try and follow the recipe, you might get it right, don't get me wrong, but most of the times you have to be careful, because I don't know if people cook, but when I cook and I look at the recipe, if you try and do it exactly like the recipe, it never really is going to come exactly as what it is, but you have to have that interpretation of it. With that, as you're doing things, you have the feel of things. So for me with taping, if you do something and it doesn't work straight away, don't expect it to work. If somebody does this and it's painful, and you do a taping and they do this and it's still painful, don't expect them to go into the combat scenario of training, come back and say, oh yeah, that was really good. What you expect them is, you've done it straight away, it's made a difference. They go in there and then they'll either tell you it felt worse, because it can happen, or yes, that was really good, or I had no change, which makes you prompt you then, okay, we need to change something. And always have the reserve in your head. I've done this, what could I do next time? Could I do it tighter? Could I do it looser? Could I change something? And again, people will ask me like, what about materials, K-tape and zinc oxide and Lefko tape? It doesn't matter the material. What matters is how you use the material and how you put it together and what it gives you. I mean, K-tape is brilliant because it's waterproof. I used to use the Hyperfix in the past and spray it on, and people used to swear at me when they take it off. Whereas the nice thing with K-tape, you put it on, it stays for a nice few days, and that can actually be a nice base if you want to then put some zinc oxide on top of it. So I actually find the combo in sports really, really brilliant. So I tend to use that sometimes more than Hyperfix these days. Sometimes I just use it as a way of weaning off also, because you go from that K-tape zinc oxide, then you just keep the K-tape, bit of proprioceptive approach, where it sort of still gives them some feeling of it's protected, and then you take it off completely. So yeah, the reply is yes, but again, it has to merit a judicious approach. I think, I'll be honest, we probably tape less than we used to do in the past. I think it's probably because we probably got better at managing things more holistically with the athletes.
Okay. Yeah, no, I think it's important what you mentioned there about, if you follow the recipe book strictly, it may not necessarily turn out the way you wanted or for the taste that you have. I have a patient at the moment who has a TFCC issue, and actually we found providing more wrist support and adjusting the way he does his hand wraps gives him the ability to train without any issues. And if he goes back to his old sort of style of wrapping with more protection around the knuckles rather than the wrist, then yeah, it comes back. So we've sort of made a bit of a combination of adding a bit of extra padding over the knuckles, because he really likes to hit hard, and then also providing a little bit more wrist support to stabilize the joint a little bit more, so that we can focus during his rehab on sort of sorting that out so that he can continue training. I think, like you say, it's one thing may not work for everybody. You've got to find that little element of your own clinical judgment with it, of getting to your own point, getting to the result for that person. Moving a little bit higher up the chain then, obviously you mentioned pronation, supination, and the proximal radio-ulnar joint and whatnot. How often do you see issues with the elbow in combat sport, especially with boxing? There must be a lot of pressure and force going through. What sort of issues are you coming across there, and how often do you guys tend to see it?
If you take your types of shots, you usually have either your straight type shots or your bent arm shots. So you think about your jabs and your crosses versus, for example, a
hooks or an uppercut.
Yeah, and even an uppercut. So an uppercut tends to be even that as like a bent arm shot. But if you see like an uppercut, difference with a hook is the uppercut goes underneath, so you don't have that overhead type shoulder movement. Whereas if you're doing a hook, you have more of that overhead type activity happening on the shoulder, but you have like a fixed elbow. Whereas if you're doing like jabbing, you don't move the shoulder as much. It tends to be more elbow. So there's a lot of elbow movement going on. So that probably comes with sort of the differences. So with your elbows, some of the injuries you get is if you're doing jabs, is a mishit. So you can jar the elbow by missing somebody. That's probably because the opponent has been really good. You're targeting to hit them, they move away, and obviously where the target was now isn't. Now, if you are really good, or your system is really good and can engage really well, you can stop before your elbow goes into hyperextension. But obviously, if you've committed yourself completely, maybe if you're a bit off balance also. So, again, starting from the feet, that's why the coaches really focus on footwork. If you're off balance, it's really hard then, because you've committed yourself to that shot. And as a result of that, you get the jarring of the elbow. But equally, especially with the elbows, in that extended position, you can end up locking yourself with the opponent, and the opponent almost does these movements. So, it happens in boxing, but probably more commonly even in sports like judo, where locking of the elbows, putting them into that hyperextension can happen. So you can have almost those bony bruising, and eventually those can obviously become osteophytic and then become loose bodies floating into the joint and start locking. You obviously have your ligamentous injuries in that extended position, not far dissimilar from your javelin throwers that obviously extend, and if they don't have a good control of the system, they can injure themselves, so like your UCL type injuries. But then it's also useful to consider flexion type injuries. If you are in a sport like boxing, but a lot of combat sports, the aim is not just to hit, it's not get hit. It's not about running away all the time, because probably doesn't look good either, although there are counter punchers that move away and are really good slippery. You think about like Muhammad Ali, really good slipper there and then comes back to you. But obviously it's about how you defend yourself. And when you're defending yourself, you get hit and the elbow, if it's solid and you can obviously contact it, you're doing well. But a lot of times the elbow can be forced into flexion. So similar as the elbow being forced into extension, you get that forcing into flexion. So you start getting obviously a similar type compression type injuring happening there. And then if you move a little bit away from your joint and ligaments, another injury that doesn't commonly happen, but does happen, and very easily you could come across a couple of cases a year, depends on the type of squads and numbers you're doing. But I said it's not as common as your joint injuries, is bicep ruptures. So, more commonly you get contusions, biceps hitting elbows, that sort of thing. Feels like a dead arm, maybe takes a couple of days. Equally, you can maybe, when you're doing that hyperextension, you maybe get an eccentric loading, a bit like a hamstring, but it's not as bad, but can take more than a few days to recover. But the worst ones that can happen is when you go and whack with full force, maybe when you contact, who knows, the elbows is almost keeps moving in a bit of an extension position. So biceps goes from being a very strong isometric to suddenly changing into a very eccentric in a switch of a second. And as a result of that, you get ruptures. I know somebody who used to be on the squad who, since he left, actually ended up having both his biceps ruptured 1 year after the other, and actually he's recovered fully. Not only that, recently he won a title towards the end of last year, so that was really, really nice to see him sort of come back from that. With that, you can see the urgency. You have a rupture of a biceps. We know that within the sort of 3-week time frame, a bit like a hamstring for the people who work with hamstrings, and you get 4 ruptures, what you want to do is operate them as quickly as possible to maintain the strength capacity, especially in your athlete population. So yeah, important to look out for that Popeye sign.
Have you ever seen brachialis ruptures in your time?
No, we don't see brachialis ruptures. What you do see is you do get irritation of brachialis. You think about your elbow, there are 3 main muscles there, is it? So you got your biceps brachii, you got your brachialis and your brachioradialis. Your brachioradialis is your strongest of the 3 actually. And in fact, if you think about most boxers, they tend to box in a mid-prone position, even when they contact. So your brachioradialis is the one that sometimes can be over-fatigued a little bit, especially if the shoulder engine starts coming down a little bit, you almost end up using more of that elbow. So you can get like irritation, tendinopathies type thing, overuse, and we've seen a few of those. And actually, if we tend to look at the elbow and the shoulder, I try and move away from the elbow there and look at the shoulder, because I don't think that in that case it is actually coming from the elbow, although worth looking at it and testing it. I like to use at certain tests like isokinetic to give me a bit more information locally, but I will look at the shoulder. Your biceps, obviously big muscle and comes in a lot with that supinatory force. Brachialis is one of those muscles, is the workhorse of the 3. It works all the time. It doesn't really get influenced by the position of the forearm. But as you can imagine, the more you start going into supination, the more the other muscles become mechanically advantaged. So they sort of take over a little bit. So brachialis, you can almost imagine, could get injured if you are in a very pronated position. So if you're doing this, and especially if you're being forced into those extensions, you can have those injuries. You can have potentially a rupture. So you can't discount anything. But we have seen some tears. I'm not seeing full tears, but I've seen some tears of brachialis. And probably, as I said, the result being more of a pronation type mechanism versus being more supinatory.
It's exactly that. The reason I ask is I actually saw someone for that probably about a year ago, and it was a case of he was training for one of those boxing gala kind of events, amateur. From the sounds of it, it was a hook that went wrong. No pain at the time really to speak of, but the next day, all of a sudden, blue, purple down the bottom of the upper arm towards the elbow, and yeah, on testing and whatnot, it was pretty clear. I was wondering how much that happens sort of at the elite level side of things as well. So with these sorts of injuries then, what's your approach in your process of elimination to find out what the root causes of going on?
I think like anything else, you have to have that sort of clinical acumen when you're looking at things. History always becomes the biggest thing, it's mentioned everywhere. People mention it, social media mention it. It's the first thing you learn when you're still undergraduate, and hopefully people still keep focusing on it. It's listening to the story, it's listening to what's happening, it's asking the questions, it's asking about the mechanisms of injuries. I've heard debates even on social media around the requirement of knowing anatomy. And I think, two things I liked about some of these debates is, one is it's important to know anatomy to know when you don't need it. But then equally for me is knowing anatomy to know when you need it, because a muscle has an origin and an insertion. If a muscle tends to do an action, you can expect it to either get injured because it gets whacked on it, that's direct. But indirectly, what you tend to see more likely, it's when it's being taken away from its normal action. If you think about the three muscles we mentioned, yes, you can talk about elbow flexion extension, but there's an element of pronation supination. So, for me, for a biceps to get injured as it's being pulled and turned into pronation becomes a bit more realistic than obviously being pulled away as opposed to supination, which is action. I'm not saying it can't, but then that's where your suspicion could be a bit more brachialis. And I think again, you mentioned brachialis. A lot of people would probably be opening the book now and thinking, what's brachialis? Is it a muscle? Is it even a muscle? Because all I think about is biceps. And he mentioned brachyradialis. Is it a muscle also? Even like triceps, we think about triceps as being one component, but the word itself is tri, is it? It's three heads. So you have to think about like the long head, the medial head, the lateral head. I don't want people to get like lost too much into mechanics. Like obviously I spend a lot of time trying to understand that from a mechanical point of view, and it's helped me to understand injuries better. But I think when you're first starting as a therapist, whether it's you're a physio or even any other form of therapist, I think you have to try and keep it as simple initially, because otherwise if you try and take on the world of information there is out there at the moment, you will literally, have a migraine every day because there's too much. And also there's too much conflict. I can deal with the conflict because I've had 20 years of experience. I think there's too much conflict, and it's dangerous sometimes because nothing is set in stone, even with the conflict sometimes. So for me, I think there is that importance of listening to that story, and then from that story then you start thinking, okay, one of the things that I learned at university was palpation as a first. I actually now go the opposite these days. The last thing I do is palpate, because I think palpation can give us skewed information, and also when you start hurting something, everything else you do after that can be a bit biased. If the first things I tend to do is actually try and do something objective like a strength test, to see what is their capacity. Capacity could be endurance or can be like a strength. You're looking at RMs, 1RM, 3RM, whatever you want to do. You can be using a handheld dynamometer, an isokinetic testing. Probably won't be the first thing I'd go on, by the way, because I think if I'm suspecting a rupture, the last thing I want to do is put somebody on an ISOK. But I could do like a manual test first that gives me the quality. So it's a yes or no test. Do they have strength? Do they have resistance? Is it painful? Yes, no. That's the only thing it can give you. Last thing I start doing is putting Oxford scales on it. 0, 1, 2, 3, 4, 5. Nothing against Oxford scales. It may have its use in certain contexts, but in sports, I'd go away from it. Although if somebody has no pain and feels really weak, it doesn't sound really promising. The next thing I would do, if I do have a handheld dynamometer, which I would suggest, is then you can do an isometric testing. And the nice thing is you can do it in a mid-range, like 90 degrees. You can do inner range if you want. It's up to you, although be careful, people go into cramps sometimes, a bit like a hamstring, but I'd go 90 degrees and then I go an outer range. And if somebody has good strength at mid-range, but is weak at outer range, again, it's giving you that more information. It also gives you something to work towards objectively after. Based on that information, I'm starting to get a clinical picture. What does that mean? Does it feel like a mild injury? Does it feel more towards moderate to severe scale? But beyond that, can they train today? So I have to give an answer of whether they can be able to train in 1 or 2 hours. I'll have to call the coach and tell him, what do I think? So I need to base it on something tangible. What is my prognosis from there? Now, I know sometimes we go into what is your diagnosis. I prefer using prognosis first. I think diagnosis can come at a later stage. I'm not in a rush for it because you could have a working diagnosis. Yeah, it could be a rupture of, let's use all the 3 muscles. You've injured either brachioradialis or biceps or anything. You've injured something in that structure. It's not as important as your prognosis. Can they train today? What are you going to do in the next 24 hours? What are you going to do next 48 hours? How are you going to measure? Are you going to scan, yes or no? What information are you using to help you, whether you need a scan or no? Because if you're that physiotherapist that scans everything that comes under your hands, the insurance are not going to like it. Probably you'll end up out of a job quickly because you can't send everybody for a scan. So the more you can build that clinical picture, the more it helps you. If you can answer the main question, which is, what am I going to tell this athlete and what am I going to tell this coach, okay, about this athlete today, and what is my sort of plan for this next 24, 48 hours, 72 into a week? Can you sort of project yourself with what you're getting now? That's a good way of starting. And you know that, okay, this is what I think is going to happen from now in a week's time. But actually what I need to do is maybe retest them in 12 hours, retest them in 24. So it depends what you're seeing.
Okay. It's quite interesting there that you're more focused on the prognosis than the diagnosis. Do you think that's also due to the fact that you're working in elite sport where time is of the essence? Would you be as skewed, shall we say, towards the prognosis over diagnosis with your general private clients that you see?
Yes, because so every private client that comes to see me traditionally comes after having seen a lot of people. I think because I don't run a private practice, I tend to see people, private clientele on the side, and usually they get referred from somebody because they've been struggling for the last 6 months, 12 months, 18 months, and so forth. Them sometimes they're referred from the physio themselves. Sometimes they're referred from a colleague, which could be the athlete themselves or a non-athlete. We talk about general population. Sometimes I do see your non-athlete population. The problem is when you try and chase a diagnosis too much, that becomes a problem because one, I always if I had a bumper sticker, my bumper sticker would be, I don't read scans. And the one on the opposite side would be, the scan doesn't tell you where the pain comes from. And I think, to be fair, those bumper stickers a lot of people would have these days because we're learning more and more that pain is a dark occult, that not even the experts in pain can't explain to you exactly where the pain is coming. Nobody can tell you the pain is exactly coming from that because all the literature seems to be confounding. You have a tear, some have pain, some don't. Okay. Great, that doesn't help anybody. But what we do know, particularly in that scenario, is that the best thing to do is try and have a working diagnosis. You tell them the first thing is what you think they might have. And I think having things which are objective do help me at least. I know some people have confounding views about it, but let me say this thing. If somebody comes to see you and they're extremely worried, they've been told that they have a tear or a fracture or whatever it is, uncertainty about things. People are telling me I have all these different things and I'm not sure what I have and I'm really worried. And you start with the basics. You do strength measures and the strength is good. You do range of motion and the range of motion is good. Although range for me comes a bit second sometimes. What I mean by that is, if you have strength, if you get good function in the areas you're doing is great. And equally, if you answer the questions of functional abilities, what can you do? Well, I can do all these things except this. Usually we start the opposite. What can't you do? Which is not a good place of starting. Because with athletes, that's the way we should start. And that's hopefully the way we start. Is what can they do? Because when you're speaking to a coach, you don't go to the coach and tell them they can't do this, and you build it up. You usually go from the top and you say they can't spar, for example, but they can do bags and pads. You know what I mean? So even in the non-athletic population, I'd go, what can you do? Even to get a bit positive, the first thing you can do is like, what can't you do? It's like we're always going on to the negative. It's useful because by the time you get to the negative, you've already say, yeah, but you've mentioned you can't do that, but you can do all the spectrum. How important is this compared to the other things? And you try and sort of correlate things with them. And I think I go with the prognosis, not because I don't have the diagnosis in the back of my head, because what you don't want to do is you don't want to go in blind. Now, blind doesn't mean that you're not considering the diagnosis, but it means that you are looking at that element of what can they do functionally, what tests have you done to give you more information, and then you're trying to rationalize it to them. You could tell them, if you want, if there's a discussion, it could be this sort of injury, it could be this sort of injury, it could be this sort of injury. Yes, we could send you for a scan, and it could show any of these three. The reality is, even if we send you for a scan at this stage, it's not going to change the way we're going to approach it, because this is what we're going to try and do. And what you can say is there's no guarantee that doing this is straight away going to make it better. Let's say, making somebody stronger or improving the range, but there's a better chance of you feel improving. And as we know, sometimes with people, increasing strength is not a direct correlation, but what can happen is they get stronger. And then a few weeks later, maybe the pain starts getting better. I've seen it a lot with certain people where, the strength gets better and that, or even if the strength is good, at least you've ticked that box and then you can move on to something else. And what I mean by that is giving you some examples. I tend to use vibration therapy. By that, it doesn't mean some new exciting machine or something like that. I use vibration, whether it is a body blade, whether it's a vibration platform, whether it is the way I use the bands. But that sort of vibration does have an inhibiting effect of pain. I've seen that. And I usually do provide this sort of information when I'm doing my educational workshops. I could start that from the very beginning, but one of the things I have to remember is if somebody's really weak and I do that, yes, it could make them improve in the symptoms, but even though they get better in the symptoms, I'm not comfortable for them to return back to training or return back to their full activities, because they're still weak. The tissue tolerance is still not good. It's important that, it's not just about managing pain. I think sometimes we fall into that other trap. We think that our job is about managing pain. It's almost like we're not physiotherapists or rehab specialists or any other title we have. We're pain therapists. No, we still have to think about tissue tolerance. Because I've had lots of athletes who had no pain at a threshold of, for example, 40% weakness, and they want to return. And I have to justify holding them back to them at the coach that is a big risk for re-injury. How many ACLs in the knee have failed over the years because of this accelerated return? Because if you do a really good focused approach, yes, you can take away the symptoms, you can make them feel more comfortable, more strong, you can give them all those parameters. But if that knee isn't ready for it, if it doesn't hit certain criteria and you've not assessed them properly, you're going to fail with your return to play. And the return to play will be flawed. You'll see it later on. So it's that balance between symptoms and the other factors you need, all the things we talk about, your balance, perception, your strength, your range of motion, your coordination. Do we look at those things? Is there a way of assessing them? Or if not, at least you consider them as part of a longitudinal type of training before returning. And the last thing I'd say is I integrate with a lot of surgeons, massive respect. But if we think physios have a lack of understanding of S&C, because that's how there is it in social media everywhere, surgeons are worse, okay? And I don't mean this as disrespect, but every time an athlete speaks with a surgeon and they tell them when they can return back to training, they always omit a period of proper S&C. Because the first thing I tell an athlete who's going to see a surgeon, I'll say, whatever they tell you, add a minimum of 6 to 8 weeks for proper strength and conditioning training, because that's what you'll need. Because they go from the period of almost initial conditioning to suddenly return back to training. Yeah, range of motion looks good. Yeah, you can start doing this from tomorrow. No, they can't. that tissue tolerance isn't ready for it. The conditioning isn't good for it. I mean, we talk about, last thing is COVID. If I got an athlete who was deconditioned from COVID, if they were, and returned them back to full training, the injuries would have been high in the roof. So you have to have the transition. And I think that's something we keep telling the athletes, but it's equally important for us to consider even in private practice, that, you have to have that period of understanding. Is it strong? Yes, no. If it's no, have you allowed that period of strength gain? And if you have done that, have you done it properly? If you actually provided a strength regime or a capacity endurance regime, if that's what they needed. It's not easy, but you have to have the right hat on at the time.
Absolutely. How do you then get people to buy in to working with a working diagnosis and focus more on the prognosis if you get pushback? Because you're Ian Gatt, you're decades of experience working in elite sport. There's a lot more weight behind what you say. What would you recommend to a younger therapist that might be listening to this when they're working with their patients to help them get that buy-in from the patient of, look, these are the goals and these are why we're doing this? And instead of the patient either not showing up the next week or just not really paying attention or giving a damn what the therapist says, what would your advice be there?
The first thing is, without almost being condescending on the person in front of them, just literally just say, look, there's lots of really good research out there showing that you could scan 100 people on the street today and you find half of them have the injury you might have and have no symptoms, and half of them have the injury and have symptoms. So it's trying to explain to them that the symptoms they're getting are not necessarily from what they have, and that almost we have to be careful that the scan can be useful as an adjunct, a diagnosis can be useful as an adjunct, as much as you're trying to eliminate the negatives. And then hopefully, even with the evidence out there, is trying to explain things. So let's say, for example, you've got a major tear in your rotator cuff. The first thing is to think about the demographic of the person in front of you. If they're young, they still have a full career in front of them. If it's a large tear, more than 2-3 centimeters, and you start putting more other factors in there, you think probably actually repairing them now is probably better, because as much as you can try and manage things, obviously in the time frame that is available. If this guy is competing for an Olympic gold in a week's time, that's a different conversation versus somebody who's got 4 years to go. But if you're somebody who's 50 years plus and they have that sort of similar scenario, the first thing you have to think is like, look, there's evidence to suggest that the tear might either stay the same or can actually get worse. It's like a rip in the jeans. You might be fine for years, or, it might rip. But the evidence suggests that repairing it, definitely in the short term, which is 1 year, 2 years, is not going to make any difference. What you need to see is how much function do they have? And you try and explain to them in the functional ability. If somebody has 90% function and they want to get an operation that's going to keep them out of 90% function for the next 6 to 8 months, and maybe more, because you don't know how these operations go, you need to explain that sometimes in numbers, as easy as that. Like, okay, you're telling me that this is where you are. Then you do some testing of strength. Look where you are. Then you look at their range. You tell them, look where you are. So if you put it as a package and you're trying to explain it, if somebody comes to you and it's like doom or gloom scenario, they're really struggling, can't do anything, and you still believe that conservative may have a point, maybe you truly believe that, maybe you're a bit cocky, maybe you think your rehab is better than anybody else. Whatever it is, though, you should give a time frame. You say, what, look, getting an operation today versus 3 weeks from now is not going to make a difference, because you've had this now for 18 months. So I'll tell you what, let's do a deal. I'm going to give you some things to do. Let's try it for the next 3 weeks, if you truly believe that there may be some difference. And let's see if there's any change whatsoever. If there's a change after 3 weeks, then we take it to the next step. Say that they've never had a scan. What you can say is, look, I tell you what, maybe we should get a scan, because it sounds like, you were really stressed and anxious about it and you'd like to know a bit more. I'm going to put it out there. The scan will give us some more information. It doesn't mean it's going to give us the answer, but it might be useful to get. In the meantime, however, we're going to try these things. I feel these things are going to help you to get better. If they don't get you better, don't worry, because we've got plan B and C in the meantime. But let's not hang our hat on a scan. It's trying to understand the person in front of you, the level of frustration they're coming with. I've heard a lot of these words these days, which are brilliant, clinical dialogue, which I've heard esteemed colleagues talk about. It should be a dialogue. If you learn about communication, which is really important, one of the things you have to be careful is using the words like why versus what. And I know it sounds semantic, but if somebody comes and says, I need a scan, and you go like, why do you need a scan? Obviously, you've just triggered them to go really like, well, why do you don't think I need a scan? And how do you go back for that? Whereas you could go like, okay, what is the rationale in your opinion for getting a scan? How did you come about thinking about a scan? And say, well, the doctor told me about it, blah, blah, and let them talk. And be careful also of close questions. Don't go like, do you think you need a scan? Or you fall into the trap that they ask you a close question and you want to answer the close question. Like, they'll ask things like, do you think I need a scan? You can go away with it to be being politically correct. Like, well, let's consider what a scan can do for us. This is what I know about scans. And you just work through them, speak a little bit and just be like, so, obviously I've mentioned maybe, what do you think about that? And just let them sort of dialogue a little bit. Sometimes they're coming for you. They want a magic recipe. They want a bullet. They want you to do hands-on. They want you to give more rehab. The last thing that they think they're going to get sometimes is somebody who wants to listen, give them some advice, but not a condescending advice that almost they know already. It's like telling somebody like, it sounds to me that you already know the answer. What I mean by that is you've overdone it in the last few weeks. You've told me that, you know that. So you are the one that needs to find a way to do it, but I can help you. I can give you some suggestions if you want. You see what I mean? Is working with them. But unless you've got something tangible, that's why I go back to like, what are the functional things that that they can do? It doesn't mean you have to do 20 tests in the clinic to know what their functional abilities. But, if somebody has a sore wrist and they can do, I don't know, 1 or 2 push-ups on their knuckles, as an example, that for me is very functional. What I mean by that, it's not that they do knuckles all the time, but if they're a combat athlete, they're going to be whacking there. If they have no pain doing that, happy days. That's a very good functional test. So sometimes you can invent your own functional tests. But then if you're doing like range of motion and strength, trying to do obviously validated tests or tests which actually provide some information. Going functionally can give you a bit more with that sort of element of prognosis and help the person in front of you. It doesn't mean, though, you don't have a working diagnosis. It doesn't mean that you don't have that at the back of your head, because, again, you need to eliminate your red flags, your pathologies. You need to eliminate things which are like really high when you're there. So, I'm not trying to tell everybody, don't ever think about diagnosis. Don't ever speak to athletes about them or anybody else, because don't forget, they're going to get chucked at you anyway. So you need to think like, yeah, you know what? It could be that you're mentioning, but there are a couple more things it could be. It could also be this, it could be that. But equally, even if it's that, let me tell you what's the evidence around this injury. And that's why it's useful then to know diagnosis, because a lot of the research out there talks a lot of times about diagnoses. You'll find literature about, UCL injuries of the elbow. You find things about fractures. You find things about TFCCs. So the more you read about those, you have them in your library. But don't latch on it, because that's what the client, the athlete is doing, the patient is doing. So if you do the same mistake and then suddenly, I don't know, they get a scan and it's not a TFCC tear, you've lost them, because they say, yeah, but you told me it was a TFCC tear, and now they found that it was a tendinopathy of the ECU, as an example. You're like, you've literally hanged your hat on the wrong place. So you tell them, yeah, it could be that, and it could be that, but don't worry, whatever it is, let's look at these things, and then we can work on these.
What is it that you think really separates out your approach then, not just in terms of prognosis versus diagnosis, but also in terms of your approach to the rehabilitation, that separates you out in the field from Joe Bloggs down the road?
Well, again, I'm not going to claim I'm better than Joe Bloggs down the road, because for me, Joe Bloggs could be doing a better job than me, and I don't even know it. What I feel is that I'm not left wing and right wing. I'm very much in the middle. And what I mean by that is I'm hands-on and hands-off, considering diagnosis, but having that prognosis at the same time. I'm listening and then I'm talking. Over the years, I think I've tried to to mold my practice based on trying to provide the best service for the person, but not in thinking that I am doing it for me to be the best person, if you see what I mean. Just trying to think what could be the best thing. So I think both the hands-on and the hands-off have that connection together. Sometimes one of the best things is when you don't need to do anything. It's a no rehab approach. It's a no hands-on approach. It's just advice. I've seen certain people get better just by giving them advice, just by telling them how to rep better, just by telling them what materials to do, just by changing the structure of the week. Oh, this is what you're doing. Let me give you my suggestion on what to do, and they get better. It's not by falling into the trap, which I have fallen into the trap sometimes, of wanting to treat somebody straight away, because I think, there isn't this thing about natural course of history. End of last year, I went on a trip on a training camp with the women's boxing team. And there was this person who was having what I would consider mechanical issues, because the pain was shifting from one side to the other side, and like this, literally within 6 hours, 12 hours, whatever. So you can imagine if you treat one side, you wouldn't know what's happening. And this person came and asked me directly, can you do acupuncture on my back? She had like tightness on her right side, QL. And I said, no, I'll tell you what to do. Just let it be. And let's see how it is tomorrow and see whether there's any change. You've already been given some things to do. You're doing some mobility stuff, and you're doing a few rehab exercises. But let me say no, we'll see how it is. The following day, she came and said, my back is still a bit sore, but it's not the right side, it's the left side. I said, that's good. She said, what do you mean by it's good? I said, well, if I treated your right side back yesterday and it got better, I would feel the indulgence to treat your left side today. I said, because I didn't treat your right side yesterday, I'm not going to treat your left side today either. And she looked at me like, what do you mean by that? You're the physio. I said, yeah, you're right. I said, what you're going to do is you're going to keep doing the rehab you've been given, which seems to be doing something in a very peculiar way, and then we see how you are. And the back fluctuated, but eventually it got better. And, these days it's much better. It's one of those unfortunate things where hands-on gives you that quick relief, and all the literature tells you that. When people talk about acupuncture does nothing and hands-on does nothing and mobilization does nothing, I'll be like, come on, guys. It does. In the very short-term effect, it does something. It's the game pleaser. It gives somebody that quick relief. And people talk about the buy-in. Oh, what's this thing about buying in? Do I need that? I'll be like, it depends on the person in front of you. And it depends up to you, whether you want to cave in, or sometimes whether it's actually needed. If you're working with athletes, sometimes it's not about caving in. If this is the final of an Olympic Games, I'm not going to tell that person, the same person, I'm not going to stick a needle into you. And they'll be like, oh, you've caved in. I'll be like, of course you cave in that scenario. And yes, it could be placebo. And yes, I could be doing nothing. And yes, there could be no direct effect. But in certain circumstances, you do what is required. So I always talk about context. And, I tweeted, God knows how many tweets over last year, and still do these days, not because I'm an avid thing, but one of the things I like to use is context. Every context is different. And so it's up to you, as long as you've been judicious in the way you've done it. If you don't have this automatic trigger that goes, oh, I'm going to needle, oh, I'm going to do this. Yeah, I've treated 10 bags before and I've needled, they've all got better, so I'm going to needle the next one. That's a dangerous approach. And that's why I've used this case scenario, because sometimes not treating gives you a better response than treating, because you'll be amazed at times by doing nothing. You think like, crikey, I've learned more from doing nothing. To ditch the hands-on, because suddenly you feel like you have to sway the pendulum on a lot of people telling you that hands-on is rubbish. What I'd say is, obviously, don't spend £1 million on learning all the techniques out there. Give yourself time, assimilate it, absorb it. I didn't learn everything in my first year. It takes time. But equally, learn when not to use it. Equally with rehab, learn when not to use it. You don't give rehab to everybody. Not everybody that comes through the door, you give them a sheet of 10 exercises, which, by the way, I don't do. I'm one of those. I either go old school completely, white sheet of paper and draw the stickman, or I hang the stickman completely because I don't give them anything. or actually I've become a bit more modern, where what I do is, I know there was a controversy this last year on social media about using pictures of patients. I tell them to give me their phone, to take pictures of them, and then I give the phone to them. So if you give them exercises, give them the minimal amount, 3, 4, 5 at the most, don't give them 10, 20. Who does that? 10, 20 exercises. Take the pictures of them doing them. Explain to them every exercise you're giving them what you think it's doing, even if maybe it's a bit bogus because maybe you're not that, but what do you think it's doing? At least you should have an idea. That's going to help your range of motion. That's going to help strength. That's going to give you capacity, whatever it is, what do you believe it's doing? Whether it's right or wrong, at least you believe that's what it's going to do. So they can understand it and understand that this is the reason why you've given me 3 exercises. If you give them 3 exercises that are doing all the same thing, you should question yourself, why have I given them 3 exercises to exactly the same thing? Do I need to do that? You see where I'm getting to it? So it's important that you rationalize everything. I think the last private patient I saw, I told them, I know you're sitting down here telling me that you probably want more rehab, but one of the things you told me is that the people that have given you rehab already, you failed, and you keep trying to find new ways of doing it. And the answer is actually you need to reduce your load. And what we did is we spent 10 minutes, 15 minutes talking about his load and how to reduce it and how to plan the week better and some things he could do. And I gave him a few exercises, but you know what? They weren't exercises he talked about. It's exercises getting a bit out of the pattern, being like this, especially with COVID and everything, is trying to go a bit out of the simple exercises, rather than focusing on too many things. So it's use that brain that we have, between those ears, it's fantastic. That's why I still enjoy doing physiotherapy, 20 years later plus, because you learn every time you sit in front of somebody. Don't turn into a technician where you're giving the same thing all the time. I don't do that with my athletes because even they come with all different sets of different ways, even if it's the same joint, a shoulder, an elbow, or a hand and wrist.
Absolutely. It's funny. I had that same conversation with a lady not 2 weeks ago where she'd seen 4 different physios. And as she was leaving, she's like, wait, these are the only 2-3 things I need to do? It's like, yeah, you've tried this multiple times over the last 1.5 years, 2 years. You've had all these different approaches, hands-on, pure exercise, pure this. Just leave it at this, calm things down a bit and see how we can build up from there. And she seems to be doing a lot better. Touch wood. But you mentioned a little bit there about different courses, different research and whatnot. Just to wrap things up, have you got any reading recommendations that you recommend for people? These are the sort of things that you want to look at if they want to find out more on this topic or anything like that?
Well, depends on what topic, because if you want communication, you probably need to dwell into the world of psychology and leadership, because there's a lot over there, which for me, quite interestingly, those are the things that you learn at a high level of leadership. And then actually they're the things that you tend to learn or need more at a physio level or at a therapist level. So I think definitely if you want to improve your communication skills, go with that. If you want to learn your wider approach, I'd say obviously it's good to sort of cast a wide net, see what sort of different forums talk about. If you are on social media, rather than just posting pictures about yourself, maybe try and see what colleagues are talking about, respected colleagues. I'd say follow them. There's a lot of people out there which definitely, can either be controversial, but makes you think, and I like that. People who are controversial for me, to my thoughts, for me, they inspire me to think whether my approach is the right approach. And then there are people that obviously agree with you, and it's equally good to see why they would agree with you. So I think it's important for me, if you are following people, don't just follow people that you like, follow people that you dislike also. I know it sounds controversial, but it's good to have the two. You need to have those two, because that's how things progress. It's like in combat sports and boxing, if you have somebody who's good at their weight and they're the only person at their weight, they're going to stagnate. If you put somebody at the same weight with them and they're the opponent, that's how both of them will improve, because obviously that's what happens. So I definitely think a little bit about What are the things you feel really strong about? What are your strengths? And are they real strengths? So keep dwelling on that. But then what are your weaknesses? What are the areas which you feel a bit weak about, and why are they weak? But equally be careful not to get influenced, because it's very easy. So you hear about this in social media, influencers. People obviously influence people. I'd say be cautious, question everything, question everybody, even the people you respect. If there's somebody out there that said to me, Gatt, I respect the things you say. I say, great, but make sure you question everything I say, because everything changes. Everything changes. And at the end of the day, this is my interpretation of what is out there. I avidly try and seek the truth. I avidly try and seek the information. I try and read research. I try and do research myself. I try and keep as informed as I can. I've probably, even myself, molded and changed over time, over the years. I try not to stay stuck there. But there's a lot of information out there. And I think, if you want to do more structured courses, and you want to follow me, obviously there's a bit of self-advertisement. Obviously, I try and provide courses through different providers, particularly though, around the hand and wrist on its own, or the upper limb complete. So, your hand, wrist, elbow, and shoulders, the sporting upper limb. So the sporting hand and wrist has gone online since the end of last year. In fact, we've got March and May True and Core. We've got 2 online days. The nice thing is we've not just taken one day and chugged it online. We've done a lot of the pre-course material to almost create half a day where people can actually sit down in their own time, go through the information. We've got myself pre-recorded material. And then on the day, try to create more discussion components. So although there's elements of teaching, I try to make it in a way where people can ask the questions. So you bring that. And then the 2-day, which was face-to-face, we know what's happening with COVID. I'm still working on it in the background to try and create an online platform. But, somebody said, can't you just put 2 days online? I said, no, because I don't want people to just faint from video fatigue. It's a hard one, is it? Like, I think when you're face-to-face, there are different ways of approaching it, and it's still fatiguing. If you do 2 full days on a screen, I think it's a bit harsh. So you have to try and find different ways of doing it. But equally, there's free media. There's information out there. Like, I know I've done information on the hand and wrist with Clinical Edge podcasts. So those, I think those the end of 2019, if I'm not going mistaken. So 3 free episodes out there. If you go and look for them, you find information out there also. So yeah, I think there's definitely more information around the topics we've mentioned today in the last 5 years than there was before that, because at least my end, I'm trying to push there. And I know there are colleagues out there that obviously are doing a bit more on that too.
Great. And just to wrap up now, where can people find you if they wanted to find out more about yourself, what you're doing, your research, and also these courses as well?
Yeah, so you'll find me under Ian Gatt. Gattman. Gattman is the nickname I got from athletes many years ago, and everybody knows me as the Gattman. So Ian Gatt, Gattman. If you go on Twitter, if you go on Instagram, if you go on LinkedIn, you'll always find me there. And if you want to send me a message direct through them, DM me, no problems. I always try and answer people. Even if you want some guidance, if I get some time, I reply to you. Sometimes people ask me guidance questions about different things. I'll try where I can to direct you, whether it is my course or general things.
Great. Thank you. Really appreciate your time. And thanks for being able to come and have a chat with us.
No worries. Thanks a lot for having us.
Well, ladies and gents, thanks again for listening in, and we'll catch you next time. As always, wherever you're listening to this, we appreciate your time. And if you have any comments or suggestions, feel free to get in contact and let us know. Until next time, peace.